Hi, my name is Noel Bell. I'm a psychotherapist in London, and today I'm chatting to Mary Deitch. Mary is the current president of SASH, which is the Society for the Advancement of Sexual Health, and Mary is a attorney and a Pennsylvania licensed psychologist. So, Mary, good afternoon to you. It's evening here. How are you doing?
I'm wonderful. How are you?
Yeah, not too bad. Apart from the Wi-Fi problems, which always creates a bit of uh, I don't know. Doesn't
Technical
doesn't
difficulty?
doesn't go by the script, does it?
No, uh-uh.
So Mary, thanks for agreeing to have the chat. Now, I heard your lecture at Williamsburg Place, the Farley Centre, which I thought was excellent, and I'll include the link to that separately because I found that was very educational, talking about the definitions and the treatment models and how to diagnose. So that I found was like really, really useful. So it's really on the back of that that I identified some questions. And I mean, essentially, talking about this area, as we know, amongst the general public, as well as clinicians, there tends to be quite a bit of misunderstanding. You know, some people think, gee, that would be a nice addiction to have, and they
Mm.
don't see the pain and the shame and where people go to in emotional states with this behavior. And and equally amongst clinicians, I found that people see it more sometimes as just a choice, a set of choices gone wrong, and they don't really see it as an addiction in the same way as substance misuse. So, um, in your time in this field, what would you say yourself around the general perceptions of problematical sexual behavior?
I think that there's a couple different perceptions that I struggle with when I'm working with other clinicians. One is that folks tend to think that when you announce that somebody is a sex addict or when you say that they have, problematic sexual behavior, they assume that you're giving them an excuse, that
Hmm.
because they have a disease, then they don't have to have any responsibility for their behaviors. And, I find that when you explain to folks what it actually means, when somebody's a diabetic and you tell them they're diabetic, they're then responsible for checking their sugars on a daily basis, eating the right foods. And it's the same way with problematic sexual behaviors. Then they are then responsible for working through those issues, facing the underlying consequences of their behaviors, and really changing how they perceive the universe. The world isn't going to change for you. Sex is everywhere right now. You have to change how you relate to the world. The other part that I find that people struggle with is they think that addiction, because of the first step, which is, powerless and unmanageable, they think that the word powerless then means that the client is able to say, well, I can't control my behavior. That's
Hmm.
not what the word powerless means. It actually means that you didn't ask for this disorder. And this disorder, once you have one drink, the saying is one is too many and 1,000 is never enough. It's the same idea, that they can't allow themselves then to start to slip back into bad behavior. The other thing that I find right now in particular is we're facing a lot of people who feel like those of us who treat this are trying to take a moralistic stance and that we're sex negative. And we're actually not sex negative. We very much want our clients to have healthy sexual lives because sex is such an important part. And we don't define anybody's sexuality for them. We allow our clients to work towards that themselves. And we're just there to help facilitate that discussion with them as to what will and will not be part of their healthy sexuality moving forward. So I think those are the major areas that I end up running into with clinicians, fellow clinicians.
Yeah, no, that's very helpful. And the question is invariably posed: what is lifestyle choice versus problem behavior? And I guess So when we think about normative behavior, we are getting into socio-cultural attitudes, but essentially, if we break it to the base level, it's when someone, even though they might be in denial, but if someone is honest with their own behavior, they can see the negative consequences in their own life or in their partner's life.
Right. Yeah, I think that that's one of the hallmarks of problematic sexual behavior is engaging in a behavior knowing that it has consequences for you or someone else. And that can even be somebody who struggles with compulsive masturbation. It keeps them isolated. It keeps them, from fully attaining what they need to at work or what they want to at work. And they feel shame and they feel anxiety and they feel a lack of connectedness. It's not to say that masturbation in and of itself is a problem, but for that person, it's created problems. And they're allowing that into their universe, and they just need to work towards a different type of sexuality. Doesn't mean masturbation is going to be off of their sexuality. It just means they have to work within themselves to figure that out. And there are folks who can engage in behaviors that others might say, oh my, I could never do that. Well, that's okay. That's not part of your sexuality. It doesn't, just because it's not something I would want in my sexual universe doesn't mean that it's not appropriate for that couple or for that person. Does that make sense?
Yeah, absolutely. So I guess that brings us on to what your definition of healthy sexual, having a healthy sexual life is.
So I think everybody needs to define their own healthy sexual life themselves. And I think that as clinicians, it does behoove us to have our own definitions, recognizing that our definitions might be a starting point for our clients, but it may not be the end point for our clients. For me, I define sexual health as behaviors that are safe and consensual, right? And both parties or a single party has the right intent around those behaviors. So clients will come to me and they'll want to figure out whether or not something is appropriate. And generally speaking, I'll have a discussion with them about any behaviors that could or could not be appropriate for them, as long as the behaviors are consensual. Where clients won't be able to convince me that something is going to be a healthy part of their life is if it involves things of non-consent, whether that's exhibitionism, voyeurism, animals, those types of things. I'm not going to be on board with that. And I'm upfront with clients about that this is my definition. If you want to try to find a clinician who's willing to help you with any of those, that's great. I'll help you try to find someone. I don't know very many clinicians that would. So that's where I start.
Yeah, absolutely. That's quite useful, because when, in my experience, some people who advocate that, say alternative sexual behavior like swinging, dogging, is okay in their life, what you'd sometimes find is one of the couple are not really consensual.
Mm-hmm.
They're doing it to people please the other, and that can sometimes lead to psychological problems, can't it?
Absolutely. And you really want to check in with both parties to make sure that it is something that they're interested in, that they're willing to experiment with. And, a lot of times it's kind of creating a contract in the coupleship of, look, I'm willing to try this with you a couple of times, and then we're going to have a conversation about it. Or I'm willing to have an open relationship as long as I know the person that you're engaging with, as long as there's been, STD testing, those types of questions are appropriate to ask. And then always the idea of, this is an ongoing conversation. Sexuality is so fluid. And what you're willing to maybe experiment with today is not necessarily something you're going to want to experiment with tomorrow. But you're, as part of a coupleship, having that discussion with each other. And that in and of itself can bring such a greater intimacy emotionally, being willing to say, I really did like that experiment that we did, but there was this one piece that made me nervous. Can we talk about that? The emotional vulnerability that occurs with that, can be very impacting on the relationship itself, even just to have the conversation if they never decide to do it. Whether it's swinging or, even just kind of some fun play in the bedroom, they're willing to have a discussion about it. That alone, I think, can bring couples closer together.
Yeah, the importance of the communication, really.
Yeah, and it decreases the shame. I think some folks have such a shame around talking about sex. You know, whether it was something that growing up they learned that it was a secretive thing, it's something that happens in a closed bedroom, it only happens under these circumstances, you know, and even if they just want to engage in a little bit of play, they may think, oh, wow, that's dirty. You know, I can't possibly ask for that. But when they are willing to move through the shame and actually ask and be willing to hear what the answer is, you know, I sometimes have to struggle with some of my clients that just because you ask, it doesn't mean the answer is going to be yes. You know, it's part of the process. You know, some of the more entitled clients might think, well, I asked and they said no, so why would I ask anymore?
Yeah.
Well, the answer is always going to be no until you ask.
Yeah, absolutely. So sometimes with other addictions, so substance misuse, alcohol, it's generally, although that can be amongst clinicians a bit of the argument as well, but if we say generally there's an abstinence-based approach to recovery from alcoholism,
Right.
and you know, there are people who are talking within that about limitations and restricting behaviors, and then getting to a point where they can quote drink normally again. But that aside, if we just take the abstinence-based approach, that is difficult to apply with sexual behavior, because sex is so much part of our everyday life, and it's linked. It's probably a prime drive, survival, our drive to affiliate. So I guess, how does someone who's watching this, who might use porn on a recreational basis, or have an exciting, colorful life with their imagination and their fantasies, how do they actually diagnose themselves having a problem, and what would the treatment sort of model be for them in terms of recovery?
So I think that there's a couple different things, one of which is to look at the intent. You know, so when you're viewing pornography, are you viewing it as a healthy sexual outlet because today you decided that you wanted to be sexual and you were interested in looking at this type of sex act? Or are you doing it because you had a really bad day at work and you want to numb and you want to soothe? Or you're angry with your partner because they won't do A, B, C, D, and E, and so you're using it in a vengeful way. I think really looking and being honest with yourself at your intent is important when it comes to things like that. You know, is it outside of, when you talk about a colorful sex life, you know, have you created kind of a value-based contract with yourself, and do your sexual behaviors match your values? You know, really looking at your own guideposts for yourself. I think that our clients do have values, and it's not something that they, you know, get rid of when they're engaging in problematic sexual health. I think or problematic sexual behaviors, I think them just being willing to look at, is this in line with my values? You know, whether that's, you know, in terms of being able to really understand for themselves, you know, where they want to go with their sexuality, or if they want to stop a behavior and see what happens. You know, sometimes stopping the behavior and realizing that you're much more irritable without it, and not just because of a sexuality piece, but because emotionally you were using it to numb, and now your emotions are surging forth. You know, all of those things are important to take a look at.
Yeah, absolutely. And if we then describe, and this might sound a bit tech speak in the therapy world, but if we talk about the DSM, the Diagnostic Statistical Manual that psychiatrists use for diagnosing the conditions, I guess gambling is the only non-substance addiction recognized, isn't it? Gambling disorder. Gaming disorder is in the appendix of DSM-5. So I guess it's a whole different debate around why sexual addiction or problem sexual behavior is not in DSM, and that would probably take us off on a completely different, a long tangent. But if, you know, so if someone is listening to this, they might think from an affect dysregulation point of view that they're using sex or porn to regulate their behavior. But where would paraphilias come in, and how can they understand sexual behavior around that?
So paraphilias are in the DSM, and they are, a different subset. They're considered non-normative sexual behaviors. Now, who got to define what normative is, I'm actually not sure. There are things in the DSM that are considered to be paraphilic disorders that I think some folks would say, well, I've engaged in light bondage. Why is that in the DSM under, sexual masochism or sexual sadism? The thing to remember about paraphilias is it's when they become interfering with your life. So if you're engaging in a fantasy world that causes you to not be able to focus throughout the day, if you're actually engaging in behaviors that are impacting you, your work, your relationships, then the paraphilic disorder kicks in. And that's something that they worked really hard on with the latest edition of the DSM, is to make sure that clients weren't being diagnosed as having a paraphilic disorder when it wasn't necessarily interfering with their lives. So somebody who is interested in fetishes, for example, doesn't necessarily make it a disorder, right? When it starts to interfere with your life or creates victims. That's the other important part to remember about paraphilic disorders. Some of them can create victims. And that in and of itself is diagnostically indicative, that's not the word I'm looking for, of a disorder itself. The thing about the DSM and sexual addiction or hypersexual disorder not being included, I would encourage folks to look up some of the work by Rory Reed, who was instrumental in getting the hypersexual disorder out. He actually wrote a nice article that I don't have the title of, but if you look for his name, you'll find it, about why he thought hypersexual disorder did not get into the DSM. Mm-hmm. And then the other piece that I'll say is that there's always been in the ICD-10 a kind of a catch-all for sexual dysfunction that includes things like nymphomania, which is the word that's still being used for somebody who has a higher sex drive or is creating issues with their sexual life. So you do have an ICD-10 diagnosis that you can use, and there's some hope that it will actually be included in the ICD-11. Sex addiction or sexual compulsivity will be hopefully in the ICD-11.
Right, and the ICD is the International Classification Directory, is it? That's not just mental health.
Right.
It's a general health diagnostic manual, but DSM is exclusively mental health.
Right. And the ICD-10 is what our insurance companies ask us to use when we're making diagnoses, at least around here. We're asked to use the ICD-10 category.
Okay, sure. Just to clarify for people listening who might think DSM, ICD, it's just a bit...
it's alphabet soup.
Yeah.
And we just continue to add to it, so...
Yeah. So, 12-step meetings, generally, it happened first in America, obviously, and the easing of the taboo, I guess, was helped with alcoholism over the years, with Hollywood people coming out as having a problem, and then it became less, it was almost like cool to be in recovery. And I think that's gradually happened in Europe and other parts of the world as well, where younger people have got sober and embraced 12-step fellowships. But my experience, I'll just be interested in your experience. My experience of working with sex-addicted clients are less likely, unlike substance abuse, to go to 12-step meetings. Has that been your experience?
My clients do tend, I guess, to maybe be 50-50. Some, are very willing to go to 12-step meetings. I understand that it can be very shame-reducing to have a group of folks who are willing to accept you, where you can talk about these things. And then there are others whose initial reaction is, I can barely talk to you about this, let alone a group of strangers. And well, what if I see somebody that I know? Which is always kind of a fun discussion, because if you see somebody at a 12-step meeting that you know, then obviously they're there for the same reason, and they may be having the same reaction to you. In general, though, once I get them to go to 12-step meetings, and I do ask all of my clients to try, because I think it can be helpful in the shame reduction piece. Also the accountability piece. I only see my clients once a week. So I can only hold them accountable, 1 out of 7 days, to have a group of people that they can rely on, who is willing, to call them on their foolishness if they're starting to get slippery in their behaviors. I find 12-step to be helpful. I ask that my clients try. if they're willing to give it a try and it doesn't work, because it doesn't work for everybody. And certain areas have stronger 12-step fellowships than others. So I do ask them to try to go.
Sure. And do you ever find there's a potential conflict in the dual role of you being a therapist to someone, counselor to someone, and them having a sponsor? Is that a kind of co-relationship that works, or can it be problematical?
I've actually found that it works. In general speaking, when I say, well, what has your sponsor said about this? And they'll be like, oh, well, I haven't really talked to them about it. We'll ask, and for the most part, we're very much in line with, what I might recommend and what their sponsor may recommend. So I do find that it's really helpful, because I know they have somebody else helping to co-parent. Really a lot of times, a lot of this process is about, them having a healthy parenting system that maybe they didn't have before. Having somebody that they can call and say, I'm running into trouble, can you help me? Knowing that their sponsor is going to be there when I can't, because I have different sets of boundaries around those types of things.
Sure, yeah. And just on the 12-step meetings, so some clients will say, I just can't imagine going into a group full of strangers. And then if God is mentioned, that can often be something that makes them a little bit more less eager. How would you sort of encourage them to go to meetings dealing with that issue?
Yeah, so that is actually one of the more frequent issues that folks have, is they don't believe in God. They don't believe that, just turning their life over to a higher power. They don't want to pray. And I understand all of that. I definitely respect people's right to have, their own beliefs. And what I encourage them to do is to find any higher power that they can believe in. And all that means is somebody or something that is greater than you. Because the recognition being that I can't do this alone. Even myself as just a regular old human being, I can't do very much on my own. I'm very interdependent, and I have, pretty healthy support systems. So can they believe in the group? Can they use the group as something outside of themselves to give them, reason, logic, stability, patience, whatever value it is that they are looking for and seeking in that moment? And it can change. Some of my folks use nature as their higher power, because it's a fluid thing, and you can get a lot of really good messages from that. There are books on being an atheist in the 12 steps, which are great. There's also the Buddhist 12 steps, which is fascinating to look at as well. And I have Jewish clients who go to, meetings within their own, Orthodox communities, because they want to make sure that it's in line with their religious beliefs. So I think there's flexibility in there if the client's willing to be open-minded, which is one of the principles of 12-step, is being open-minded.
Yeah, and there's plenty of CIAs, Catholic Irish alcoholics.
Yep. Yes.
With plenty of those. So in terms of the 12 steps for alcoholism, for substance abuse, alcohol and drugs, has a concept of addiction, but also a disease model as a framework for the recovery then. And that is often something, like the Stanton Peels, the Mark Lewises will talk more about harm reduction, that it doesn't have to be fully abstinence based. It might initially be, but then you can get to the point where you reconnect with a safer part of yourself, embrace fully with community, higher consciousness, and then you can potentially drink again socially. That's one argument around substance abuse recovery. But what do you think about the 12-step model, the addiction model for problematical sexual behavior?
So I was raised on the addiction model. I was trained under folks who thought of it as an addiction. And so I do believe that it is a brain disease in a lot of cases. Do I believe in abstinence? No, absolutely not. We can't live an abstinent sex life. Now, initially, we do ask clients to abstain, because then it's about reintegrating and figuring out with good intent, what sexual behaviors are going to be part of your sexuality. one of the nice things about two of the more predominant 12-step sex addiction-based 12-step meetings around here, which is SLAA and SAA, is they allow the clients to define their sobriety or what behaviors are considered, maladaptive for themselves. They don't ascribe to any sort of tenets of what would and would not be a healthy sexuality for them. So I think that that's very beneficial to remember that, in this case, sex addiction is a lot like an eating disorder. We want folks to recognize that this may be a coping mechanism that you're going to go back to, but there's new ways to manage it, and we want to incorporate sex and sexuality back into your life in a way that does feel fulfilling and does feel nurturing to you, and is safe for you and everybody involved in your life.
Yes, because, and with other behavioral addictions like gambling, I found it very difficult to see clients outside of the abstinence-based approach. It's very rare in my experience that people go back to gambling and can just have a few bets.
Right.
Yeah. So I guess if we think about, well, I guess technology, I remember hearing Pat Carnes talk about him saying that the internet, and specifically fast broadband mobile, has made porn explode. And he often, he was saying, who could possibly cope as a partner for what is on offer in the internet? So it provides massive pressure on relationships. If someone becomes addicted, it's like in the candy store, they've just got so much choice. So do you think mobile telephony in particular has created a game changer, that it's actually fueling addiction, or is it just that there's already susceptibility to addiction there in the first place?
So I think that folks may have already been, susceptible to problematic sexual behaviors, but I think the internet has probably increased the likelihood for some folks. With every invention that is wonderful, there's always a downside, and even with, the idea that pornography, it helps folks feel more open about their sexuality, but there's so much to look at, and where the pornography industry has taken it to greater and greater levels, allows somebody to become desensitized faster to things that maybe they would have never even thought about, in terms of sex and sexuality. And so while there is some research on the benefits of pornography, there's a lot of research about the downfalls of it. And particularly when our younger folks are seeing it, starting in their teenage years or even younger, they don't understand what they're viewing, and they don't understand the realities of it. So I do think we have a generation that might have more, maybe not necessarily addiction, maybe it doesn't rise to the level where it's creating, vast consequences, but it's creating some impact on their sex and sexuality. All of the apps that are out there now for sex, those types of things, I used to have to do a little bit of work when I was younger if I wanted to hook up. Now we don't have to do any work for it. And so I think socially it's also creating a different dimension that nobody was really prepared for. But the recognition that we also, those of us who didn't grow up with this, we have to understand that when we're working with clients of a different age group, we're entering into their universe and their reality. And we can't impose, well, back in my day, that's just not feasible anymore. So I can't tell my clients to not be on the internet. It's how am I going to be on the internet safely? Yeah. How am I going to use social media safely? Because they're going to have social media, and it's a part of their universe that we can't just say, well, it's not working for you. No, we have to figure out a way to help them make it work for them. Yes,
although if you think, I generally subscribe to the view that it is a game changer. For 5G mobile, the increased capability, you don't have to be in one fixed position now, so you can just carry this to the device to wherever you want to go, and it's increased privacy that probably fuels the usage. But then when someone says, you know, if you look back in social change in the past, when the electric light bulb came in, there was supposed to be dire consequences for the future of mankind. We would never sleep properly again. If you think about, I don't know, rock and roll, it was going to pollute kids, punk rock. And somehow society evolves and
Mhm.
civilization evolves. So are we, as, I mean, this is probably a question that's often put to me. It's not really a question I necessarily believe in, but as clinicians, are we kind of overstating the risks associated with this new information age?
Is it possible that we're overstating it? Yes. I do think that it can be a very polarizing argument. And I think if we recognize that there's a gray area about it, we don't need to say that it's going to harm everybody, you know, or that it's, you know, it's going to be problematic. I think we need to own that it has also created a lot of very valuable things for folks. And, you know, we have a generation who has way more information at their fingertips than we ever did, you know, and so they know more, you know, than we do. They have a different definition of friends, but they have friends from all sorts of other cultures. They have friends from, you know, different walks of life that, you know, I didn't have growing up. And so I think we also have to remember everything is gray. You know, we can't just assume that it's bad. You know, I have a colleague who talks about the gaming industry and how there can be a lot of benefits to folks gaming. So I think it really behooves us to not take a polarized stance on this.
Yeah.
It does have risks, but it has a lot of benefits.
Yeah. So, I mean, if someone has a problem with sexual addiction, and let's just assume that they accept that it is a problem,
Mm-hmm.
and they go into treatment of some description, whether it's residential or outpatient, um, or 12-step meetings. What then is a normative state for them to go back to? Like, what would their future sex life be, which is not in the addictive kind of realm?
So that's a difficult question, and that's also kind of the best part of our jobs. I think that getting folks when they're in crisis and getting them to kind of put down all of their sexual behaviors for a time period, that's a difficult thing. And giving them emotional intelligence and learning healthy coping skills, and recognizing and honoring that sexual behaviors give us so much. They make us feel empowered. They make us feel wanted and desired and loved, even if it's a false sense. Those things are very important. And so helping clients recognize that they can get those things in a healthy way. You know, they can feel in control in a way that's healthy and not destructive to them is the fun part of our jobs. Honoring the addiction, honoring the behaviors for what it gave them, and being willing then to grieve that those behaviors aren't going to be a part of their life. But then the really fun part is, what is your sexual health? Okay, so what are you going to experiment with? What is your intent? What is your mindset? What is your emotional state? You know, and I have clients who will say, like, let's work towards bringing masturbation back into your life. Let's work towards, you know, sexual health with your spouse or partner. And what's that going to look like? And again, it's kind of like going back through adolescence with a different kind of a brain. And it's, to me, it's the fun part of our jobs, is giving people back a state of peacefulness around their sexuality, recognizing that, you know, in the background, you know, there may be temper tantrums that flare up where they want to engage in the negative behaviors again, but that's not necessarily where they have to go, if that makes any sense.
Yeah, no, it makes total sense. So if we're talking about how to treat someone then with sex addiction or problem, we have to be careful with terminology, don't we? With problematical sexual behavior,
Mm-hmm.
where do you start in terms of assessment then?
So I do a lot of different assessments. I use a lot of the hypersexuality disorder assessments. I also do attachment assessments on intake. and I do basic standard depression inventories, anxiety inventories. There's also a lot of really great assessments on, you know, are they a high self-monitor? Like, what's their emotional intelligence like? And so every client is different. There's no one way, I don't think, to go about treatment for this. I do find helping them understand what emotions are, you know, that emotions aren't bad, they're just data, and how we manage that data is important. Most of my clients, I do have to walk through a basic inventory of the different emotions and what we're going to do with them, and recognizing that when you feel anger can be such a powerfully motivating emotion. You know, what are you going to do with it now, as opposed to maybe pushing it inward, becoming depressed over it, feeling shame around it, or exploding? You know, what can we do? All emotions have an evolutionary reason behind them. So I find that giving them emotional intelligence is helpful. A lot of my clients I do schema-focused therapy with, because there is underlying attachment wounds. And I'm not saying that everybody with problematic sexual behaviors has underlying attachment disorder or trauma issues. It's just those who seek treatment, in my experience, frequently have those issues. I don't get to see the folks who are able to put away the behaviors without needing therapeutic help. So I don't know what those folks look like, but I just know my crew. So I do a lot of schema-focused therapy, which helps us get at the way somebody translates reality based upon childhood wounds. And I also use a lot of ACT therapy now, which is acceptance and commitment therapy. I find, because I see a lot of clients who are young adults who maybe don't necessarily buy into, you know, a certain type of process, if I can get them to ascribe to their own values and then working towards a values-based system. It also includes using mindfulness, which I find very helpful to get somebody to just take a beat, you know, take a step before reacting to an emotion, and recognizing that we don't have to let our thoughts and emotions control us. We have to be curious about them and wonder about them. And so I find that the ACT therapy really helps as well.
Yeah. The mindfulness is used in, is it DBT, dialectic behavior therapy?
It is. I think it is.
Yeah.
Yeah,
Yeah.
I'm not trained in DBT, but it is, I believe, a huge part of that.
Yeah, it's in the UK. It's mainly used within a forensic setting.
Oh, that's interesting, because I am finding here with my forensic clients, I'm having to introduce that to a lot of them. So that's fascinating. I love that they're using it. I think it's wonderful.
Yeah, because it's actually used in forensic settings within the National Health Service, and often CBT is the primary one-to-one therapy within the NHS. But where the NHS can be creative is often with the use of that CBT in that forensic setting. Yeah, mainly at group level. So they'll do mindfulness-based approach at group level.
Oh, that's great.
Yeah. So you think attachment styles is quite useful to understand. So would you bring in psychoeducation around? Would you go into Bowlby's work around any developmental ruptures around the secure base, or would you get that technical with them? How would you actually explain in your one-to-one work around the attachment stuff?
I think it really depends on the client. I have some clients who really relish the underlying basis and the research behind things. That can be a double-edged sword. I have a client right now who I like to say he mentally masturbates. The more articles and books I give for him to read, the more that he devours them and then thinks about them, but then doesn't actually make change, because he actually is just stuck in the knowledge realm of things. And that's great, but it's only a tiny first step. But I do explain to him, I give every client the ECR, which is the experiences in close relationships. And I explain to them the differences between the different attachment styles and how that push-pull, if they're insecure, can look, and what it looks like in sessions even, or in group, or with their 12-step fellowship, where they are kind of somebody who maybe wants to look more on the outskirts, but wants to be close to people, but is anxious about it. You know, where that comes from for them, I think can be really beneficial, and for them to have a knowledge and a a template really to look at as they're walking through these relationships, and understand that it's not something we can fix overnight. It takes practice. And so that, I think, is really important for clients to recognize, that they don't then feel shame that, well, I have this attachment disorder, now I can't fix it. No, we can work towards helping each other with this.
Absolutely. And do you use much of TA, like the parent-child, adult, and Cartman stuff around victimization?
The Cartman's triangle is something that is pretty frequent in psychoeducation in our groups, absolutely, and getting them to understand that, how that impacts, how they spin around the triangle can impact how they're relating in relationships, and really, any tool that can help them understand their place in the world and how they translate reality. And so Cartman doesn't work for everybody, and attachment doesn't work for everybody, but maybe, looking at it again through a schema lens will help, or through a CBT lens sometimes even.
Yeah, absolutely. I notice I'm saying absolutely a lot, but I'm just finding a lot of resonance. So could we talk just a little about total sexual outlets?
We can. It's really not something that I bring it up in my training only so folks understand when they go back and read hypersexual disorder from the beginning. It seems to be a sense that they were going to try to figure out what actually would be hypersexual. And that seems to have dropped off, and where it's not about how many times you orgasm in a week. It's not about how much pornography you view. Some people can view 20 hours of pornography a week and it not have any impact on their universe whatsoever. Some people can watch 2 hours of pornography a week and they fall to pieces. So it's not necessarily about the number or the amount, as far as I understand the research. It's about what that does for you or to you.
Yeah. Yeah, so it's a bit like, it's not your relation, it's not what you drink, it's the effect whatever you drink has on you.
Right. I think we both work, with alcoholics who, drank once a week but got insanely drunk to the point of blackout once a week, versus somebody who has a drink a day and maneuvers on their life. So it's not necessarily, there is no amount that makes one a sex addict or sexually compulsive. It's the obsessive thoughts. It's the impact it has on their world.
Absolutely. There's that word again. So personality factors, do you think, obviously it's very individualist.
Mm-hmm.
It's difficult to be generalistic, but is there any sort of threads you can pull together in the sort of clients you see with struggling with problematic sexual behavior?
I think a lot of our clients end up looking like they might have cluster B personality disorder, so borderline narcissistic, antisocial. I find that I don't generally like to diagnose personality disorders, because what I find is that the more you dig into their history, these maladaptive interpersonal behaviors actually were adaptive at one point, and so getting them to really look at where these behaviors came from, how they relate, why their thinking, quite frankly, grew up the way that it grew up, then they can start to shift and understand. There is some research that people who are more narcissistic, say, in tendency, spend more time on the internet and spend more time in the social media worlds where they can get that feedback loop. There's some research to suggest that. There's some research to suggest that they may also be more impulsive. And those who are willing to put more stuff out into the universe on the internet maybe don't have as much of an ego strength as other folks. Some research it's not a black and white. Again, we have to recognize that there's a gray in here as well.
Yeah. Well, I remember hearing the Williamsburg lecture, and you said around assessment that you always ask clients, is there anything I didn't ask you?
Yeah.
That can be quite illuminating, can't it?
It really is, and one of the things I explain to my clients is I'm not perfect, and I will, I try to pick up on every thread that I can. But so if I say, typically I ask, is there anything that I haven't asked you that you were afraid I was going to, or is there anything that you've purposely not told me? And you'll be amazed at what they say and what secrets they were hanging on to, or just waiting for me to ask, or waiting to have room and space to talk about certain things. They do frequently answer that question, or those two questions. Yeah.
And so when clients typically get, say, and let's look at a 90 days, say, abstinence,
Mm-hmm.
do you think there's common things that happen in their kind of internal states after, if they can deal with the abstinence, and
Yeah.
then, and you're suggesting let's do some abstinence and see what happens? Is it a bit of a naive question to sort of ask, is there kind of general stuff that you have seen typically comes up? Is it stuff around attachment? Is it fears? Is there past traumas? What kind of that was buried comes to the surface?
Well, I think first, most of my clients go through a process of feeling incredibly irritable, teary. They're more susceptible to just being sensitive and emotional. And so kind of those emotions start to rush up for them. And so working with them on that. The other scary thing for a lot of my clients is they do have very vivid dreams, and an increase in nocturnal emissions. And so helping them recognize that we can't control our dreams. That's just your brain processing everything that's been going on during the day, or not going on during the day, as the case may be. And so getting them prepared for that. And then, yes, understanding that, interpersonally, I took away your whoopee, essentially. I took away your security blanket, and we have to put something else in place there. And so all of these things are good things. We just have to be willing to work with them and to talk about them. And, there's nothing that I'm not willing to hear about. And there's nothing that we can't talk about, whether it's you had an argument, with your boss, and, okay, well, what's that about? How did we get through that? Or, again, they start to have some really interesting fantasies. Let's talk about that, because fantasies can be a huge indicator of what really is going on for you and what you're missing and what you're seeking. I think that just trying to cut off fantasy and not be curious about it can be dangerous, because you miss so much rich information that is really contained in those fantasies.
But you're obviously quite comfortable with the material, so they would feel comfortable with you to disclose.
I hope.
Yeah.
I hope they feel comfortable. We'll have to ask them. No, I think, one of the things I try to train clinicians in is just being comfortable talking about sex and sex terms. What I find is when we ask the questions, they will answer them. So if you ask somebody on intake, how many times do you masturbate a day? They'll answer that question. How much pornography do you view? What do you view when you view pornography? What are your search terms? What's your go-to fantasy? What do you do when you go to a strip club, as opposed to just me assuming I know what they do in a strip club? Because all of that is very rich in detail and very rich in clinical material for us to work through. But I have to be comfortable saying those words. And, so sometimes I encourage clinicians just to practice saying the word masturbation. Bring it up in casual conversation with somebody that won't look at you like you have 5 heads. But the more comfortable we are saying those words, the more comfortable our clients are going to be. Is what happens. I think for me is because I'm willing to ask, they're willing to answer.
And what about the clients who won't tell you very much at assessment stage, who might be waiting for the rapport and the trust to develop?
For me, I rarely run into that. Once we get through the intake, and I don't start with sex questions, on the intake. I start with family history, drug and alcohol use, the standard intake questions. And so they have somewhat developed a rapport. But I also know, people come to me because they know that I work in sex. They know that I work with problematic sexual behavior. So I think they're more comfortable just from the outset knowing that I'm going to ask these questions. Now, are there times that it comes up maybe in the second or third session, like, oh, there was this behavior that I haven't talked about yet? I have a sexual behavior checklist that I give all of my clients to fill out as well. So it gives us a guide of what we need to discuss. It has a bunch of different sexual behaviors on it, and they just check off, I've engaged in these behaviors, and we talk about them. So I think I'm unique in that they know going in I'm going to ask.
Yeah. What if there's the say they haven't been arrested for looking at inappropriate material, but have fantasies about it or are actually doing it? What's their general disclosure to you around that?
And that's one of the things that clinicians, need to know what their state laws are around those, or their country's laws around that information. I think that for clients, if there's no contact offenses, but this is all part of your informed consent at the beginning, that what you are required to do under the law. And it's really important to be upfront with clients what you're going to do with that information should they disclose it. I have colleagues from all over the country who have different ways, because of the different mandates, at least here in the States. Every state has a different version of what needs to be reported. So I have clinician colleagues who have come up with some fairly unique ways to allow clients to talk about this material without fear. But it really is, one, knowing from the outset, what your state's laws are, and then two, explaining that to the client, and helping them through it. Now, there are cases where, because we have to report certain things here in the States, and I'm sure it's the same everywhere, it can be really beneficial for the client to report that themselves. So if somebody has a contact offense, to say, okay, we're going to work on this together. We're going to call children and youth together so that you are able to be accountable and you are able to really own this information. That in and of itself, to get a client to that position, can be amazing for them.
Yeah, and since we're on that topic, it's a topic where someone, particularly is male and considered a perpetrator. When I was going through my psychotherapy training, there was a lot of people, when we used to have sort of put your hand up for would you work with this group or that group, or what groups would you not work with, invariably female trainees would say they wouldn't work with male perpetrators.
Oh.
Yeah. So I'm kind of often left wondering what was it they were afraid of. And then if everyone said no to that client group, do they get any help?
I think that it's really important for clinicians to know what material they can and can't work with. So I think it's good if they say that they can't. I think one of the things that is really beneficial is for clinicians to hear about different stories, and maybe to hear from an offender what their story was, what their journey has been, because that, I think, opens the door to, oh, wow, these are human beings who made mistakes, sometimes drastic, disastrous, horrific mistakes that affected many people, but they're human, right? And they want help. And so if you're willing to do that work, if you think you can hear, you do have to hear their stories, and you do have to hear about their offending behaviors. If you're unable to do that, then absolutely you shouldn't work with that population. But if you are, to be able to help somebody so that they don't create more victims, so that they can have a fulfilling life with a relationship and a job, it's amazing, humbling work if you're willing and able to do it.
Yeah, and if we're on that topic of the inevitability of progression within sexual addiction, when is it? I'm not sure what the question is here. Hopefully, you'll understand it. But or is it inevitable for if there's desensitized use of pornography that there'll always be progression to extreme pornography and including inappropriate minors? Or does that come about through something else? Is there a maladaptation in another area? It's not just the progressive addiction. Do you know what I mean?
Yeah, I don't think that there's necessarily a progression with every problematic sexual behavior client. I think that some clients have watched the same type of pornography for the last 20 years and they're happy and it works for them. And, and by happy, I mean, it's still maladaptive, but, that is what they need. There are a lot of clients, though, who need more and more, and that's what we would consider kind of a tolerance idea under an addiction model, is that they do need things that are different and unique. And I have clients that would be considered almost like collectors, where that's where the obsessive compulsive piece comes in. They want to collect every different type of pornography that they can. Or if there's one, actress, for example, that they really enjoy, they want all of her works, regardless of what she has done and what's happening in the pornography. And so I think that there's different reasons behind the progression for clients, and we need to own that we don't know all the reasons. And it's really in conversations with the client that we understand why they progressed, where they progressed to. The universe of pornography right now is so vast that it's not necessarily that they would end up in an illegal pornography. And the path to illegal pornography is different for everybody as well. I think some folks maybe did have a pedophilic, predilection for, prepubescent children, and the internet made it possible. Versus some clients just found themselves going deeper and deeper. Maybe they started with an attraction to adolescents who were developed and it just slowly went lower. Some clients, unfortunately, my younger guys, started viewing pornography when they were children. They started viewing children and not realizing that it was illegal. So I think that we have to be mindful that, yes, there might be a tolerance effect for the type of pornography or the amount, but it's not necessary that it's going to go to an illegal nature, or that that's a predisposition for all of our clients who end up viewing child pornography. A lot of them probably weren't having any pedophilic interests before that happened. And again, with pedophilic, the diagnostic criteria being that it's prepubescent, so undeveloped children. But in the world of child pornography, we also have to remember that that does include adolescents. That is child pornography, at least here in the States. I think it's the same there as well. So.
Yeah, and like you say, because some of the young adolescent guys who first start watching porn, porn stars would have been uncool who looked like their mom.
Right.
Yeah. Mary, you also see physicians as part of your private work who have engaged in violation of boundaries.
Right.
Now, that sounds like would be an interesting insight into what was going on. Is that, I mean, how is that work for you? Do you see many?
So I do a couple different things with physicians. I see them individually. The bulk of my work with physicians recently has been doing assessments. So I do assessments for physicians' health programs to see if the physician is safe to practice. Is there an issue is always the first question. If there is an issue, are they safe to practice? Under what circumstances are they safe to practice? Or how could we get them to be safe to practice? So I might say, right now, I wouldn't let so-and-so, Dr. So-and-so, be alone with clients, male or female patients, but here's how I think we could get him to that spot. Or I would say that the physician is safe under a prescribed set of circumstances. Maybe they only see male clients. They always have to have a nurse monitor with them, those types of things. And so that's fascinating work, because physicians, with boundary violations, sometimes it can be, they have affairs with nurses, to inappropriate touching, to diverting medications, those types of things. And so helping them it's a little bit like detective work, figuring out where they went off track, but also trying to figure out how we can help them and keep people safe as well. Providing public safety is an important part of those assessments, making sure that this physician isn't going to endanger anybody else.
Yes, no, it sounds like it would be interesting. And is there any kind of generalities around presenting issues? Is it something that, it's probably very individualist?
I've seen the whole wide array of potential boundary violations. And so there really isn't, again, one of my things is everybody is different. And so I haven't met one physician who's the same as anybody else. So.
Yeah. Wow. Well, we've covered an amazing amount of ground. If anyone is watching or listening, who feels they might have a problem in this area, there's lots of resource online. They could Google SASH, and there's lots of resource on there. I mean, you could just Google sex addiction recovery, and there'd be a lot of resources. What would you specifically direct people to?
Well, self-serving, I would send people to sash.net, which is sash.net. If they go to the resources link, they'll find online resources as well as clinicians. There's a therapist directory and an organization directory, and it does include recovery coaches and interventionists, so folks who might be able to help. If it's a partner, for example, who is the one seeking help first, I think a lot of partners realize that this has been traumatic for them and that they need assistance, maybe even before they intervene on their spouse who might be the addict. So yeah, I would send people to sash.net. There's also other great websites for sex addiction, whether it's looking for treatment or 12-step meetings. But there's, the internet, again, is a wonderful, wonderful universe if you're looking for the right stuff.
Yes, and some really good books. I mean, I can vouch for anything by Pat Carnes. Who would you? Rob Wise in the UK. Paula Hall. Is there anyone else you'd like to throw into the mix?
So Thaddeus Burchard, who's also from the UK, just published another book on treatment. You mentioned a lot of the big names. There's a lot of really great authors. There's a book that SASH publishes, actually, which is for female sex addiction, one of the only books, I think, on females, because it's a little bit of a different world. So that's Making Advances. That's on our website. There's just tons and tons. I think it's finding, what you relate to and finding an author that you relate to. So. Yeah,
absolutely. There's so much there that it's just a question of what your particular take is. So, like you, the way you do assessments for clients. Now that we've had this interview, what would your question that I haven't asked you that you would have, or afraid, or may have wanted that you could mention now?
There's so much. I don't even know. I think we did cover a lot. I think depending on if you're, a potential client looking for help versus a clinician, there's a lot of questions that we didn't answer, and that maybe we didn't even think to ask. The most important thing, I think, for folks to realize is that, people are very much harmed, whether it's for themselves or for others, by problematic sexual behaviors. I don't, quite frankly, care what we end up calling it. There's a huge argument in our field right now is, do we call it sex addiction? Do we call it sexual compulsivity? Do we call it hypersexual disorder? Do we call it out of control sexual behaviors? All of the different groups that are arguing about this can all agree on one thing, and that is that these behaviors are having a tremendous impact on our clients and their sense of self and their sense of well-being and their sense of sanity. So I don't care what we call it. And I don't, if you're looking for a therapist who treats sex addiction because you like that model, that's fabulous. But if you find that you don't agree with the sex addiction model, there's great other therapists out there who will help you, who won't necessarily have you ascribe to a certain model. And I think that's important for you, if you're somebody looking for help, is to realize that there is help and there's a wide variety of help. And all it comes down to is everybody wants our clients and our fellow human beings to have a safe, content, healthy life. And so, find the clinician that you can really bond with. Find somebody, when you talk to them over the phone, that you like their answers about what they say. If you're not looking for somebody to, tell you what your sexual health should be, and I quite frankly don't think that should be the clinician's role, ask them, what do they believe sexual health is? Do they have their own definition of it? Do they, if you're looking for somebody who is willing to talk with you about swingers clubs, is it something that they would say absolutely never can be appropriate? Well, then you have your answer as to whether they'll be a good clinician for you. So I think being curious about what you're looking for. and being curious with the clinician before you even walk in their office, quite frankly, asking them those questions over the phone. There is help, and there are people who want to help and people who won't judge you. And that's going to be the most important thing for your journey if you're looking for help. If you're a clinician, our job is to be non-judgmental. And so to really be sure that you have your own sense of self settled first, and to recognize that this work will make you challenge your own sexuality and really think about your own sexuality, and it will evolve. What you may have agreed to 10 years ago is not going to be the same as you start to do this work. And having a good support network as a clinician, I'm lucky here in the Philadelphia area, there's tons of us. There's not tons, but there's a lot of us, and we do help each other out, and we do talk to each other. And there's been days that I've gotten done with sessions and I've had to call my colleague at 10 o'clock at night and say, I need to process. Are you up?
Yeah, help.
What? Help, yes.
Help, yeah.
Yeah, and we do. And I think it's important for any clinician not to get kind of stuck in their own isolation. But I think when you're talking about something so personal as sex, to make sure that we have extra, support systems, because there's a lot of trauma involved, whether it's even just our clients inflicting trauma on their partners, or our clients were traumatized as children. We need to keep our own, we talked about kind of walking the walk, right? And that's really important for us, I think, to remember in this field. So
yeah, because our degenerative side could get triggered quite often by the client work.
Right.
Yeah. Well, it sounds like we potentially might have a part 2, because there's plenty of stuff there, and
that would be great.
Yeah, and we didn't mention the conference, but the SASH annual conference is taking place in Salt Lake City in October.
Yes, October 5th through the 7th. We have an annual conference every year, and we change locations. This year we are in Salt Lake. We're really super excited about the different presenters that we have, and we're doing our first community day this year on Saturday. Instead of it just being workshops for clinicians, we're actually inviting the lay community, and we have amazing panels going on to help educate. And again, it's not just about the downside of the digital world. It's about the whole digital world, and there's a lot of really great things out there. So I'm really excited. Definitely you can check out our website, sash.net, for more information, and I hope to see somebody there. That'd be great.
Yes, absolutely. Well, thank you, Mary, for giving your time. You've been very generous with sharing your time and your knowledge, and I hope the viewers have got some insight into this area. And as you say, there's so much resources that one can avail of. And thanks for persevering with the technology problems earlier. We had Wi-Fi down and all that.
Absolutely. This has been fun. Thank you.
You're welcome. So chat soon, yeah?
Yes, absolutely.
Take care. Bye.
Bye.